Hello, I'm Jean-Pierre Després, Scientific Director at the ICCR, and I'm joined this afternoon by two friends, partners at the ICCR, Dr. Paul Poirier from the Quebec Heart and Lung Institute in Quebec City, Canada, and Robert Ross from Kingston. And we're going to discuss the issue of how abdominal adiposity is assessed in clinical practice, and whether or not we pay attention to some simple vital signs like waist circumference. So, gentlemen, I think the evidence that has been published in the medical scientific literature of over the last 25 years is overwhelmingly clear that a large waist circumference as an anthropometric index of excess abdominal adiposity predict a further increased risk of diabetes and cardiovascular disease at any given BMI. So I'd like to start with you, Bob. Your own perspective. You have been working with primary care physicians a whole lot over the last few years. Do physicians do it? Do they do it?
Do they measure waist circumference is the question, and the answer is unfortunately not to the extent that we would like given the evidence. When you look at how solid the evidence is now, independent of gender, independent of race, that waist circumference predicts risk even beyond the common cardiometabolic risk factors that are normally gathered by our primary care colleagues. You would think that it would be measured routinely in practice to stratify risk accordingly among their patients. And in addition to its utility as a useful tool to screen risk, we also know very well now established evidence that changes in waist circumference can occur with or without weight loss. So not only does waist circumference characterize risk beyond the weight scale, but it allows us to identify the efficacy of our treatment strategies beyond what the weight scale can tell us. We have some work to do to educate our primary care colleagues that this measurement is important. Certainly, we're encouraged over the last 4 or 5 years with the increase amongst clinicians who measure waist, but you'd be quite correct in characterizing the general state of affairs as one that would be indicate that we have some further education to do.
Yeah, I would agree with you that I think awareness has improved over the last decade, but we still have work to do in that respect. Paul, you are a very prominent academic cardiologist when it comes to the time to link obesity with cardiovascular complication. You're heavily interested by this issue. In the field of cardiology, do you think we have made progress regarding the importance of measuring waist circumference? What's your opinion?
To be real honest with you, I mean, cardiologists are not even there. I mean, they've been treating risk factor pretty aggressively. But for those guys, treating risk factors is giving drugs for blood pressure, for diabetes, for lipids. So they don't recognize, they do know probably that obesity is a problem. But the definition of obesity for them is BMI driven. So waist circumference is not even there. And if it's there, they would ask, is there a drug to treat waist circumference? Or is there a drug to treat obesity? And if not, then there's nothing we can do. Because they're used to be pretty aggressive in terms of treatment. They put stent, they do pacemaker stuff, so they're technically oriented or pretty aggressive in terms of treatment. So when we're talking about obesity and adiposity as a whole, and waist circumference, they say, oh, it's there's nothing we can do. It's a failure. So why should I measure it? Even if they're bulk literature or they're saying that people that are waist circumference even if they got our disease, okay? Those people that are obese, those are the ones you'll see again in the CCU. So you need to take care of it. And you know, sadly, they're not taking care of it.
And on top of that, in the field of cardiology, there's further noise because we have also this evidence that patients with heart disease that have large BMI are survivors. You know, the probability that they will not die is actually greater. So this brings a lot of noise, and there's some evidence coming from European countries that it's not a matter of BMI, right? Could you comment on that?
The paradox, they call it the paradox of obesity. So it doesn't make sense. You know, once you're obese, you're at risk of having coronary artery disease, and once you've got coronary artery disease, being obese protects you. It doesn't make sense. So it's only a way of measurement of adiposity. And again, in those European countries, they're in France, particularly, those people at a given BMI who do have high waistline, they do worse. So it's only a matter of measurement.
Yeah, I think this waist circumference to explain the obesity paradox in cardiology is certainly something that will need to be revisited. Now, we all would like our patients to be more physically active and to eat better, but in reality, in clinical practice, it's a different situation. Bob, could you comment on the kind of support that we would need in primary care, for instance, to help patients improve their nutritional and physical activity habits?
Well, you ask a very important question indeed, and one that's very, very central to research right now. How do we get our patients to adopt and sustain lifestyle-based behaviors? What we know to this point, and it's unambiguous, is that 2 points, really. The first one is that knowledge alone doesn't change behavior. So the primary care physician suggesting to his patient that he or she increase physical activity and consume a healthful diet by itself doesn't work. And even more important, we know from the literature that physicians who see their patients maybe 4, 5, 6 times, just them, trying to coach their patients to adopt physical activity and consume a healthful diet, that also, unfortunately, does not work. The evidence would suggest that that's a failure. So what we need to do is we need to provide the physician with the resources, with the trained personnel that we have from our universities. Right now I speak to the kinesiologist and the dietitian, people who are trained in cognitive behavioral techniques, trained in nutrition, trained in physical activity, to work with the physician to help to change the behaviors of the abdominally obese, high-risk patient. To be fair, the model within which that would work is not readily apparent right now. We're not sure. But quite frankly, we can't wait for the best possible evidence to support the notion that we need to help our physicians with these kind of people. I think that the best available evidence would suggest that the kinesiologist, dietitian, working in concert with the nurse and the family health practitioner is a winning combination. The emerging evidence is starting to suggest that could give us the results that we want. So I fully support and advocate for that notion, and know that the chair does as well, and something that we'll be working on creating that message over the next few years.
Correct. And now, Paul, as an academic cardiologist, you're the head of the rehab program at the Quebec Heart and Lung Institute, and you have been also involved in lifestyle modification program from a science standpoint. Could you comment on the disconnect, the gap between the science that you have generated in terms of lifestyle modification versus the service you can offer in clinical practice in your rehab program?
Yeah, there's a big gap, because if you look at the science, the well-designed, well-performed data out there, it's clear that we can achieve great things with physical activity and diet and all the supports we need. In rehab program, we don't have that kind of support. We're doing what we can, but we don't have that kind of support. If we would have that kind of support, we would show the same results probably. Because people, when they get into the rehab program, they've been doing for 10 years before their event that eating good and being physically active is a good treatment. Still, they had a heart attack because they didn't do that for the last 10 years. So this timing is very interesting to change behavior. But we need people to teach those guys.
And you deal also with because they are all over the place, obviously in academic hospitals. You deal with patients with type 2 diabetes, and this is certainly the same problem there. You know, if they are lucky, they're going to see a dietitian maybe once or twice a year. How can we expect that?
There's no way. I mean, people will be, teach to this and that, and after 2 weeks, it's gone.
Bob, a last comment on the return on investment in terms of prevention program. Your thoughts on that, please.
Well, I think that certainly we are going to have to change our reimbursement policy in most countries in the world if we're going to engage the personnel that are appropriately trained with respect to behavior modification, nutrition, and exercise. But I am of those that believe that it's either pay me now or pay me later. We know very clearly that lifestyle-based chronic disease is costing us millions of dollars, regardless of the country that we are in. We must do something to prevent the onset of that disease and then manage it when it comes. If not, then in many countries we will not be able to sustain the cost of type 2 diabetes associated with abdominal obesity. So there will be a cost right now, but I think it will be well placed and will save money in the long run.
Well, that's certainly indeed the crusade of the chair. There's clearly the public health issue, the prevention, improving globally the nutritional and physical activity habits of the whole population. But for all those patients, that are abdominally obese who are managed by you, Paul, in cardiology or by the pneumologist because they have sleep apnea, this large population with type 2 diabetes, we all believe, I guess, that they would certainly benefit from support from dietitians and kinesiologists. So, gentlemen, I'm sure we are going to revisit this issue often in the future. Thank you.